Artificial nutrition and hydration. It is a medical treatment that allows a person to receive nutrition and hydration when they are no longer able to take them by mouth. It is given to a person who cannot eat or drink enough to sustain life or health. Doctors can provide nutrition and hydration through intravenous administration or by putting a tube in the stomach. This requires technical skill and has many serious risks. Professional skill and training are necessary to insert the tube, to make decisions about how much and what type of nutrition to give, and to monitor for side effects. It does not offer the comforts that come from the taste and texture of food and liquids. Based on the principle of autonomy, patients or families have a right to choose whether or not to receive artificial nutrition and hydration. This can be for social or religious reasons. Healthcare providers and facilities have a right to set policies as to whether they want to care for patients who decline artificial feeding or hydration. Based on the principle of beneficence, there are beliefs that artificial nutrition and hydration can improve nutritional status, reduce aspiration pneumonia risk, assist in healing of decubitus ulcers, improve functional status, and reduce hunger and thirst. Based on the principle of non-maleficence, there are beliefs that artificial nutrition and hydration can reduce aspiration pneumonia risk, reduce hunger and thirst, and it is a low-risk procedure to the patient. Based on the principle of social justice, society has an obligation to protect citizens who are unable to take care of themselves. Society should not deny basic care to individuals based on their mental status or other medical conditions. Based on the principle of distributive justice, we must weigh a physician or facility's ability to provide skilled versus unskilled care. We must consider the cost of artificial feeding and whether there is spoon feeding with an attendant, which is labor-intensive and not reimbursable. The goals for nutritional support in a comatose patient includes the following: minimizing the deleterious effects of the early and ongoing hypermetabolic and hypercatabolic phase, to support body defense mechanisms, and to create the optimal recovery of the nervous system. Another question to ask is the provision of nutrition. Can it be given enteral or parenteral? Practically, there is no real controversy between the enteral or parenteral route of feeding. They are complementary. Comatose patients with severe malnutrition, that is, those who have lost greater than 5% of body weight, should have immediate nutritional support after hemodynamic stabilization, whereas in patients with normal nutritional status, a period of 5 to 7 days without any vigorous efforts to achieve the appropriate goals is acceptable. Here are some ethical issues that arise in the use of nutrition support in the comatose patient. First, justification for the decision to withhold or withdraw treatment and the principle of equality of access to the treatment. Second, parenteral and enteral nutrition are to be considered as a mode of medical treatment. Third, if the imposed burdens are greater than the anticipated benefits, nutrition support may be discontinued in accordance with the principles and practices of governing the withholding and withdrawing of other forms of medical treatment. Here are some examples of common objections encountered as moral constraints on withholding or withdrawing nutritional support. The healthcare providers perceive it as an obligation to provide ordinary versus extraordinary care, to continue treatment once started, to avoid causing death, and to provide symbolically significant treatment. The obligation to promote the good of the patient is a basic professional duty of the healthcare provider. This obligation underlies the requirement to evaluate the benefit and burdens of a treatment from the patient's perspective. If from the incapacitated patient's perspective, the burden of a treatment outweighs the benefits, it is ethically permissible to withhold the treatment. The treatment should be provided when, from the patient's perspective, the benefits outweigh the burdens. When it is unclear whether the benefits or burdens are greater, then it is advisable to continue treatment as a time-limited trial. What happens when artificial nutrition and hydration is given to patients who are at the end of life? What are the typical circumstances in which artificial nutrition and hydration appears to be counterproductive? When someone with a serious life-limiting illness is no longer able to eat or drink, it usually means that the body is beginning to stop functioning. Artificial nutrition and hydration will not bring the person back to a healthy state. Artificial nutrition and hydration can increase suffering in patients who are dying and no longer have the ability or interest to eat food and drink liquids themselves. Artificial nutrition and hydration can add more discomfort to a dying person's physical symptoms, such as bloating, swelling, cramps, diarrhea, and shortness of breath. It is important to remember that the person's body is beginning to shut down because of the disease and dying process, not because of the absence of food and liquid. Withdrawing and foregoing treatment. A treatment that has been considered for a patient but not begun is said to have been withheld. Once that was started and then discontinued, then that would be withdrawn. The term foregoing refers to the process of either withholding or withdrawing. Let's take a look at this excerpt from the Kinlan case. The New Jersey Supreme Court ruled that patients have a right to refuse medical care on the basis of unstated but implicit constitutional right of privacy. If you can recall, it was a friend of Miss Kinlan who stated that Miss Kinlan had stated on one occasion that she would not want to live a life where it is not living. In the Cruzan decision, the U.S. Supreme Court agreed that competent patients have a constitutional right to refuse medical care. In theory, this right of patients to refuse medical therapy can be limited by four countervailing interests. First, the preservation of life. Second, the prevention of suicide. Third, the protection of third parties such as children. And fourth, preserving the integrity of the medical profession. In practice, these interests almost never override the right of competent patients and incompetent patients who have left explicit advance care documents. Who, then, can make proxy decisions? There is general agreement that competent patients have the exclusive right to refuse medical care. Even in cases where the patient's wishes may conflict with those of his or her family, the patient's right to refuse care is determinative. For incompetent patients who left living wills or other advance care documents, the wishes in these directives are determinative. Recently, several state Supreme Courts have limited the right of families to decide for incompetent patients when there is no advance care directive or formal appointment of the proxy. These courts have accepted that when a mentally incompetent patient is in a persistent vegetative state, comatose, or terminally ill, family members, even if not formally appointed as proxy decision makers, can withdraw life-sustaining treatments based on prior conversations with the patient or their understanding of the patient's values. For a surrogate, not formally appointed, to decide to terminate life-sustaining treatments from an incompetent but conscious patient, the patient's statements must first address the condition that the patient is in, not a closely related one. Second, identify the specific intervention being considered for termination. And third, indicate that the comments are to be used to guide medical decision-making. This level of specificity for guidance of surrogate decision is a change. Importantly, this view has limited application. It is only for incompetent but conscious patients who did not formally appoint a proxy. These limits on surrogate decision-making may have limited impact on withdrawing life-sustaining treatment for cancer patients because they are terminally ill, a category of persons in which these courts have granted greater discretionary judgment to the family. However, they also emphasize the value of having patients complete formal advance care directives specifying their wishes regarding life-sustaining treatments and who they want to be their proxy decision maker. What are the requirements? Competent patients have the right to refuse medical care and can use whatever criteria they deem acceptable. It is their values, whatever they are, that guide the choice. In the words of the California Supreme Court, the right to refuse medical treatment is basic and fundamental. Its exercise requires no one's approval. It is not merely one vote subject to being overridden by medical opinion. The controlling decision belongs to a competent, informed patient. It is a moral and philosophical decision that, being a competent adult, is the patient's alone. Similarly, for incompetent patients who left advance directives that specify the interventions they want or do not want, their values determine their choices. Regarding incompetent patients who either appointed a proxy without specific indications of their wishes, or who never completed an advance care directive, this question remains controversial. 4 guiding criteria have been proposed. First, the ordinary and extraordinary care distinction. Second, futile care. Third, substituted judgment. And fourth, best interests. First, some advocate a distinction between ordinary and extraordinary care, which distinction holds that ordinary care should be administered, but extraordinary care may be withheld. Many ethicists and courts have concluded that this distinction is too vague and has too many conflicting meanings to be helpful in guiding surrogate decision makers and physicians. It is recommended that the ordinary-extraordinary distinction not be used to justify decisions about stopping treatment. Second, in the late 1980s, some argued that physicians could terminate futile treatments. Unfortunately, the term futility has been used inconsistently. In general, it is now agreed that there is no objective standard of futility. The term merely conceals subjective value judgments about when a treatment is not beneficial. Third, many courts advocate use of the substituted judgment criterion, which holds that the surrogate should try to imagine what the patient would do if the patient were competent. Therefore, substituted judgment becomes more of a guessing game, or a legal fiction at best, as some courts have called it, than a way of fulfilling the patient's wishes. Fourth, the best interests criterion holds that the surrogate should evaluate treatments by balancing their benefits and risks and select those treatments in which the benefits maximally outweigh the burdens of treatment. As a matter of practice, physicians rely on family members to make decisions that they feel is best and only object if these decisions seem to demand treatments that the physicians consider non-beneficial. Without a perfect solution to the problems raised by proxy decision-making, this approach may be the most reasonable one in difficult circumstances.